Today we're going to talk about Chapter 21, Drug Therapy for Asthma and Other Respiratory Problems. It's a very important chapter, I think, because as a nurse you're going to see a lot of asthma and a lot of respiratory issues, excuse me, including COPD. What you need to know about asthma is on this slide. This is a normal airway. This is an asthmatic airway, and as you can see, the bronchial tubes are surrounded by smooth muscles, and here they're thickened and getting inflamed. Here they're having an asthmatic attack, and the smooth muscles are tighter. The air is trapped in the alveoli, and the wall is thick, and they start having bronchial constriction. These are the triggers, and you can go over those yourself. What I want to do is talk about asthma itself. It is a chronic disorder of airway constriction. So bronchial constriction is the term you will need to remember. The bronchial tubes constrict as that smooth muscle gets inflamed, and therefore the patient can't get any air. The symptoms can come and go, and the breath sounds, if you listen to your patient and they're not having an attack, their breath sounds will be clear. If they have an attack, you're going to be hearing what? Wheezes. A lot of wheezes, high-pitched wheezes, that sort of thing. COPD is chronic obstructive pulmonary disorder. So there's a lot of things that are categorized as COPD. Chronic bronchitis, emphysema are two of the main ones. The symptoms never go away. Once someone is diagnosed with COPD, then it is an issue that they have to deal with for the rest of their lives. There's permanent damage to the alveoli. There's a thick, sticky mucus, and patients will cough. Their lung breath sounds will not be clear as they are in asthma. And as you know, they will be taking Guaifesin or Organodin or one of those medications that help liquefy the secretions in the lungs so that the patients can cough up that thick, sticky mucus. Many COPD patients are on oxygen. So to treat these conditions, we use bronchodilators to reduce the bronchoconstriction. So you want to dilate the bronchial tubes. We use anti-inflammatory medicine to decrease the swelling. And we use the mucolytics, which is the Organodin or one of those, to thin the mucus. This is just a diagram of someone who has emphysema of the COPD, and this is a normal lung. So bronchodilators in your textbook on page 343. This is a very important slide that I want you to master. We talk about SABAs and LABAs, short-term beta adrenergic agonist. And remember, we talked about it, agonist and antagonist. And the agonist are drugs that bind and help with certain physical parts of your body. So they help dilate the bronchi quickly. And they stop active acute attacks. So they're considered a rescue inhaler. For sure, I want you to learn this. Short-acting beta-adrenergic drugs stop acute attacks. And those are breathine, Proventil, exophenix that we usually talk about, terbutaline, albuterol, levobuterol. These are the ones that you will see that are in the little red tubes that they puff in their mouth. I think you all are going to do albuterol in your clinicals, and but you'll see a lot of people that carry those around. Those are rescue inhalers. So those are used in an emergency when they're having an acute attack. Then you have long-term or LABAs, and these are considered a controller drug. They help dilate the bronchi slowly to help prevent an acute attack, and they should not be used when having an immediate attack. These need time to build up in your system, so people will be put on these and take it every day, once or twice a day, and then it gradually builds up. And Ceravent is one, and that lasts 12 hours. And Foradil is a new one that's on the market. Brio is one you may have heard of. And there are other ones that are long-term. So it's important for your patient because often they'll have both of these medicines. And it's hard for them to understand which ones they're supposed to use. So they take the long-term ones, the LABAs, they take those every day. Then if they get into a bronchial spasm, then they'll take a short-acting. These have side effects, of course. The most common is tachycardia and hypertension. And so you need to be very aware of that, especially let's say you have an elderly person that has atrial fib and you give them something like this. You really need to monitor their heart rate and their blood pressure because in the elderly or the young especially, these medicines are a lot more potent, and so you need to really pay attention to the common side effects. So you're going to listen to the bilaterally, you're going to listen to their breath sounds before and after the inhaler or the nebulizer if they take it as a nebulizer. So you also need to know that breathing can cause hypertension. And so you're going to watch for these other complications: chest pain, flushed skin, dizziness, headache, and any of those you may have to change the dose on medication. So for bronchodilators, you need to remember that you listen to the breath sounds before and after to determine the effectiveness of the med. You listen for wheezes and watch for the complications. Then there are other medications that they can use, such as cholinergic antagonist, known as an anticholinergic drug. So that's Atrovent. And then there's xanthines, and that's like aminophylline and theophylline. And that was a drug of choice years ago when my children had asthma, but they don't use those very much now because they had so many severe. But you will use Atrovent. So what do you want to teach your patients? You want to teach them to avoid the triggers that we didn't go over, but dust, pets, grasses, that kind of stuff. You want them to demonstrate how they know to use these two medicines, that they have a complete understanding of which one they use when. Also, how to take the medicines. Using those little puffers are sometimes difficult for our patients. And then you need to teach them about side effects, what they need to notify you about, and then you need to know. Anticholinergics also, they have with those urinary retention, blurred vision, eye pain, nausea, headache, because a cholinergic drug does the opposite. So anti-cholinergic, then you're going to get urinary retention, blurred vision. So you need to also understand those. Method of delivery, you can read that, but you need to wait 1 minute between puffs, and rinse the mouth out after use, if they're using any kind of the steroids, because they can get thrush. So you can do an aerosol, a dry inhaler, a metered dose inhaler, and you're going to watch for thrush. Candidus, is thrush. So prophylactically, you're going to treat bronchial spasms with inhaled corticosteroids or steroids. So in addition to using the bronchodilators, you're going to maybe need something for the bronchial spasms, for that inflammation part of the asthmatic attack. So you're going to use corticosteroids, and they reduce the inflammation in the bronchioles. So Flovent, Pulmicort, Solumedrol, Asthmacort, all of those are inhaled corticosteroids. And those are the ones you're going to watch. Make sure they rinse their mouth out after every treatment, because they can get thrush. They also can use mast cell stabilizers and eucotrine modifiers. But inhaled corticosteroids are the ones that are most generally used. We talked about Advair, and then Symbicort, or combined meds nowadays that are used. Page 346 talks about when you're giving 2 or more drugs, you give the bronchodilator first, and then you wait 5 minutes, full 5 minutes, before giving any other drugs. So let's say you're going to do a bronchodilator and then a corticosteroid. You wait 5 minutes between, don't get rushed. You give that time to work and to get into their system before you hit them with another drug. So you need to wait 5 minutes before doing that. Mucolyptics we talked a little bit about, but they help loosen the secretions for COPD patients, and also respiratory infections. So when you sometimes get an upper respiratory infection yourself, and you take guaifenesin and Robitussin, one of those, that helps liquefy the secretion so you can get them up. And then you also need to take a full glass of water. So that's chapter 21. I'm sorry I'm hoarse this morning. I just want to re-emphasize the importance of this chapter. And let me see here in my book. There's some things that I want to. We talked about the bronchoconstriction and the inflammation. Just remember this PowerPoint here. Very, very important. We compared asthma with COPD. And I told you COPD is chronic and it cannot be reversed. Once someone is diagnosed with COPD, then it's going to be a lifelong problem. So certainly the elderly are very often diagnosed with COPD. Asthma does come and go, so it can go away. But when people, especially children, are dealing with this, then it is life-threatening. Both of these are life-threatening. We talked about bronchodilators to reduce the constriction, anti-inflammatory meds, which were the corticosteroids, to decrease the swelling, and mucolyptics, which is like Robitussin, to help thin that. We talked about, I want you to know this chart, SABAs and LABAs, and look in your book, Proventil, ProAir, that was the one I was trying to think of. A lot of people nowadays use ProAir. It's the little red atomizer that I see a lot of people using. And then the long-acting it's like Ceravent, Foradil. So you need to look in your book and look here and know the meds that you're going to be giving. You know to listen to their breath sounds before and after. With asthma, you're going to hear wheezes, high-pitched wheezes, because the air is coming in and the lumen is very, very inflamed and swollen. And so that's why when the air tries to go through, it becomes high-pitched, just like a whistle when you whistle. And then we talked about the anticholinergic drugs that are also given sometimes Atrovent. We talked about that. And that's in your textbook on page 344. What you want to teach the patient about side effects. The steroids, you need to know these. Mast cell stabilizers. The combo meds, the eucalyptics. They take those when you have bronchitis, something like that. I told you bronchodilators cause tachycardia, hypertension. They also cause dry mouth and tremors. The people that are taking these, especially the elderly, really have problems with these side effects. You need to assess for chest pain in any patient taking any of these medicines. I told you that if you're giving more than one medicine, you need to wait 5 minutes before giving the second or third med. We talked about anti-inflammatory medicines. We talked about Brio, eucalyptics. I think that's it. It's good on page 353 of your textbook to test yourself about basic knowledge. Those are some good questions at the end.